In 2005, this patient went in for surgery to correct a deviated septum. Surgery was uneventful, and he was discharged home with a prescription for 30 Percocet. The recovery went well, and when he went back to talk to the surgeon, he was happy to report that he did not need to take any of the Percocet. And the surgeon informed him that, yes, it was pretty much a painless surgery. So when he asked the surgeon, well, why did you give me 30 Percocet? He said, well, it's just expected. And just in case you haven't figured it out, this patient is me, a little bit younger. And at the time, I viewed that with some curiosity and did what I thought was the responsible thing at the time. I gave the medicine to my wife, who's a nurse, who put it up high up away from any possibility that small children could get at it. But we didn't lock it up. And if you asked me what happened to those 30 Percocet, I honestly couldn't tell you.
So this takes us to what we studied. We wanted to look at opioid prescription practices and why doctors would prescribe pills like that and how it could be altered in the future. So that's us in Western North Carolina. You've seen this graph before. Our study was looking at specifically Western North Carolina using the Western Carolina Medical Society. Miriam Schwarz was also on our project with us. And we wanted to look at prescribing habits, opioid prescribing habits, and then hopefully turn them over to educators, officials, medical people who could do something about that to implement changes. And interestingly, one fact from the CDC is over this 10-minute med talk that we'll be giving, one person will have died of an opioid prescription overdose. So for our methods, we created a survey. We sent it out over the Western Carolina Medical Society listserv, and we used it on SurveyMonkey, so it was a quick form that people could fill out easily. We had two main survey components. One was a qualitative. We left open-ended questions, and we asked people, one, what they thought the biggest reason for the opioid epidemic was, and the second was what would make your prescription habits more comfortable to you, prescribing opioids more comfortable. And the second one was more quantitative, so demographics, prescribing habits, and then comfort and importance. So demographics that we looked at, it went out to physicians and physician assistants. We looked at age, years since graduating residency, what kind of practice size they worked in, what kind of practice type they worked in. We looked at best practices. So if you're prescribing opioids, are you doing a urine drug screen? Do you have a written policy that you implement? Do you have a pain contract with your patients? And then comfort and importance with prescribing opioids. Are you comfortable prescribing them in the first place? Are you comfortable with using written policies if you have them? So that's where we started.
So these were our results. We sent out over 1,400 surveys and got back about 142 back. We eliminated 4 of those because people indicated that their specialty just didn't prescribe opiates. There was one respondent who said they just chose not to prescribe any opiates. And we had 3 people who filled in the demographic part but didn't complete the rest of the survey. And that left us with 134 surveys for us to look at. So this is just a snapshot to look at who responded. Overwhelmingly physicians, and this kind of represents the representation in the Western Carolina Medical Society, which was the database that we used. Years since residency was pretty evenly distributed, and also age. Practice size was also fairly evenly distributed, although the majority were in the 3 to 8 providers group or the 20 plus. When we started to get into practice type, we ended up with so many permutations and combinations of I'm independent, or I'm employed, and I'm in an ACO, or I'm a resident in a FQHC. So we felt like we had to simplify this to make some sense out of it. So if you look at the big pie chart here, what we did was we broke it down. So all the blue were employed. Gray were in FQHCs. The purple part of the graph were independents, and the reds were people who were in residency or medical school. And this actually accounted for 92% of the surveys that we got back. So What we then did is we took each demographic factor and we did a pivot table matching it up to whether or not they were using best practices and how comfortable or important did they think these things were, which was a lot of pivot tables. I now know how to do a pivot table. And here's some of the highlights. So we asked, did you have a written policy or pain contract? And overwhelmingly, those in an independent practice said no, that they had neither. As we go through these slides, I want to point out that red is bad, green is good, and yellow is intermediate. Okay? We also asked if they were using the controlled substance reporting system. And once again, those in independent practice tended to not use this, while those in residency and those in FQHCs said that they were using it about 100% of the time. We then asked if they mitigated risk or prescribed naloxone. And both independent practices and those who were employed tended not to use it as much. Then we looked at the size of practices, and we see a trend here in that smaller practices with 1 to 2 providers tended to not have a written policy or pain contract. They also tended to feel that the written policy or the pain contract was not important. And they seem to have more comments to make as well, those that were in the smaller practices. There was a curious little bump in the 46 to 55-year-old age group who said that they were not using the controlled substance reporting system. And we're not really sure what that means. It may tie back to their experiences with when the fifth vital sign was introduced or a lot of other factors in this. And then we looked at comfort prescribing opiates. Interesting thing here was that older practitioners seemed to be more comfortable providing opiates, even though they weren't necessarily using all of the best practices. So comfort didn't necessarily translate into comfortable or feeling that I should do urine drug screens or I should have a written policy or a pain contract. The other interesting thing here is that younger practitioners tended to be less comfortable, even though they tended to be doing all the right things.
So this brings us to our more qualitative data. So these were the open-ended questions that we just let people write in whatever, and we made some word maps of all the words, and the bigger words on here are the ones that were mentioned more frequently in these open-ended questions. This was for what do you think was the main cause of the opioid epidemic? And there's some, pains on there, patients. I think medical doctors is an important one that we feel that we're part of the system. Chronic, I think vital is an important one that's on there for the fifth vital sign. So this was very impactful to me and kind of looking at it to see what people thought. And then our second open-ended question was how do we make it more comfortable for prescribers who are prescribing opioids? I think some of the important ones on here were time and access for patients, that if you had more time, you might feel more comfortable. If patients had better access to people, more comfort. So there are just a lot of interesting things that came out of this. I think CME is an important one on there, risk management, so a lot of different terms that came up. And then from that open-ended question, we figured out some themes that were reoccurring, and so we made some quantitative data. And the most important theme that came out of it was that providers would feel more comfortable if they had a supportive policy to support their prescriptions. Second most important was actually avoidance of opioid prescribing altogether, which was kind of interesting to me. So where do we go from here? This is good information that we collected about opioid prescribers in Western North Carolina. We learned that there are some good targeted groups that we can intervene on. So instead of just widely casting a net, we learned that independent practices may not be using the written policies as much. Older practitioners might not be using the CSRS, so that's something that you could talk to them about. And then smaller practices might also need some help getting the best practices into their everyday life. And then from the more qualitative data, providers want these supportive policies. The STOP Act is great, but I think there's a lot more that could happen to support providers and making it safer for patients throughout the state. So thank you.